All right, let us begin as everyone continues to join us. My name is Grace Rubenstein, Editorial and Communications Director at Health Begins. Good morning and good afternoon, wherever you might be joining us from for today's webinar on strategies to sustain health equity investments against headwinds. So we're really pleased and honored to have you with us today. And I have just a few notes on how this is going to work before we get started. First of all, you should know this webinar is being recorded. And that also means we'll be sending you the recording as well as the slides by email after the webinar. So you don't need to write down every single thing you see if it helps you be a little more present. All of your lines as participants are going to be on mute throughout the hour, but we really value a dialogue and a conversation. That's going to happen in our chat window. And you can place a question there for the panelists at any time you think of it. We'll be monitoring that chat throughout the hour and gathering questions up to ask our panelists towards the end during our Q&A session. And the chat is also a space where we can support and share resources with each other. Just to get that started, I'm going to demonstrate. Here's a little note about who I am and where I'm coming in from today. I'd love to see other folks do that. If you can just take a moment, find your chat window, open it up to send to everyone, and give us a hello with your organization and your location. It'd be great to see who is joining us today. Hi, Glasha. And Vasem. Oh, wonderful. Washington, Wisconsin, Vermont, Kansas City, Nashville, Atlanta, Kentucky, all over the map. It's really great to see everybody here. Keep that coming, please. So this is a 1-hour presentation with time for a Q&A reserved at the end. We ask that you bring respect, curiosity, and hopefully a bit of joy to the conversation. You are more than welcome, in fact, encouraged to share resources in the chat, things that might be useful to everybody. We only ask that you not use the chat for any commercial promotions. With that, let us move into our objectives for today. Navneet, many thanks to my colleague Navneet for running our slides. We can go to the next one. Thank you. Okay, there it is. So our aim is that by the end of the hour today, you will be ready to describe the current systemic challenges to sustainable investments and financing for health equity and social determinants of health equity work. You'll be able to articulate more comprehensive approaches to financial modeling and a more compelling and accurate definition of value that can help address current threats to health equity and SDOH-E investments. And finally, you'll be able to identify at least 2 concrete opportunities to sustain health equity and investments in this political and economic environment. So plenty for 1 hour, and I think we can actually do it. Next, please. It is my privilege to hand it over now to my colleague and our moderator for today, Health Begins Vice President of Learning and Innovation, Glasha Marcon.
Thank you so much, Grace, and good morning, everyone from rainy Oakland, California. So thrilled to be with you all today. To kick us off, I'm just going to share a little bit about Health Begins and what we do, but to kind of ground us first, I wanted to say that we're here because the work of advancing health equity and sustaining investments in it has never been more urgent or more challenged. And with major cuts to Medicaid and shrinking federal support for social programs, many efforts are facing real headwinds. I know a lot of us are experiencing this. But the need for programs and investments that address factors upstream of healthcare haven't changed. And if anything, the need has grown. So today we'll hear from some courageous leaders who are finding practical and strategic ways to sustain and strengthen this work. Before we start, if you can go to the next slide, I would love to share a little bit about Health Begins. So we are a national mission-driven consulting firm and a field catalyst that helps Medicaid-serving organizations exceed health equity and social needs requirements and shift upstream conditions that heal and harm people and achieve long-term impact for communities harmed by societal practices. As you can see, we've been very busy doing this work and supporting over 350 communities. Next slide. Our work is informed by several key observations. Health and social inequities are experienced as harm. Social arrangements, including structural racism, put people in harm's way. Equity is not just the absence of harm or unjust differences, it's the presence of systems that promote and preserve healing, opportunity, and justice. And since structural violence and harm is spatialized, institutions need a portfolio of strategies to advance health and social equity that is place-based, outcomes-focused, and works across levels of change. We're really excited to support courageous leaders who need support and solidarity to implement these strategies and to transform institutions, relationships, and communities in the process. Next slide. We are going to start with Rishi Manchanda, who is going to frame the current headwinds and share specific strategies for sustainable health equity investments. Dr. Rishi Manchanda is the CEO of Health Begins and a physician leader known for pioneering the upstream approach to health equity. His work helps healthcare organizations address the social and structural drivers of health from clinical practice to policy, and he's also the author of The Upstream Doctors. After that, we are going to be joined by Dr. Christina Harris and Dr. Karen Hacker for a panel discussion. Dr. Christina Harris is the Chief Health Equity Officer at Cedars-Sinai and a professor in the Department of Medicine at Cedars-Sinai Medical Center. She brings deep expertise leading health equity initiatives at health systems and has years of hands-on primary care experience in historically underserved communities. At Cedars-Sinai, she leads institution-wide strategies to reduce disparities, improve care quality, and build stronger community partnerships. Dr. Karen Hacker is a health policy fellow in residence at Emory University's Rollins School of Public Health, and she's the former director of the CDC's National Center for Chronic Disease Prevention and Health Promotion. She has led large-scale national efforts in chronic disease prevention, maternal health, and social determinants of health. And she is known for bridging community and policy and brings decades of experience turning equity goals into real-world results. So to start us off, Rishi, please take it away.
Thank you so much, Glasha. This is really an honor and a treat here just to be in this space with not just you, Glasha, and the rest of our Health Begins team, but also Dr. Harris and Dr. Hacker. What an honor. And thanks everybody for joining us. If you go to the next slide here, I'll do some level setting kind of remarks just to orient to the objectives of the day before turning it to the panel, our main kind of conversation. So in setting the table here, we're really identifying that public and private investments and financing to improve community health and health equity have, despite some notable efforts in recent years to be able to invest more, unlock more capital, on balance, we're still seeing relatively meager investments societally and including from the private sector, including the nonprofit sector, in efforts to really advance community health, especially when you compare it to the vast amount of money that goes towards other investments. For example, in healthcare, healthcare, as we know, is rife with low value kind of care, and there's efforts to help reduce low value care and improve efficiency, but there's still a lot of money that's not going towards real health improvements, especially at a community level. And a lot of the efforts that do exist, which are innovative and notable and have been demonstrated to achieve real outcomes, especially by addressing the social and structural determinants of health, like food, housing, transportation. We see the evidence that these lead to better outcomes and can lower costs, but efforts to do so still remain fragmented. And this is because of a number of systemic challenges. So the efforts that do exist still remain somewhat fragmented in the ecosystem, and then there's still systemic barriers that prevent even the most bright spot solutions out there from scaling. And as Glasha mentioned, this political and fiscal environment with so many federal cuts and also assaults on public health and healthcare programs, it makes coordination and alignment of the funding, the financing, and the capital more urgent than ever. If we go to the next slide. So what we've been doing in Health Begins for the past couple of years, especially in the past year, is to kind of map out these major systemic challenges. This is a busy slide, so and actually I'm wondering, Navneet, would you mind just refreshing? This is like a small technical. Would you mind refreshing the screen share for this? Oh, actually, you got it. I think that's yep. Then you can share it again. Thank you for that. So what I'll voice over as we're getting the slides just updated, just briefly. Thank you. Is that for today, I'm not going to, just back one slide. That's my bad, sorry about that. So when we get that slide back up, I wanted to highlight that we've been mapping systemic challenges for financing and investments in health equity for some time. The primary ones that we're going to focus in on today are, you just go back here. You can just press back on the arrows when you're ready, Nippy, sorry. So as we, yep, right here, perfect. Thank you. And sorry about that. So, we're going to focus in on a couple of these systemic challenges, and yep, you can advance just to highlight the ones that we're going to focus in on, financial modeling and cost effectiveness, as well as things related to funds and funding models. So we've been mapping, these are just two specific challenges within a broader ecosystem of systemic challenges, and I'll speak about them more broadly later. But for today, if we go to the next slide, and thanks, Navneet. Let's talk about some of the financial modeling kind of challenges that we've seen. We know, and Health Begins, if you've been following our work, has been among several organizations that has long been critiquing the limitations of conventional ROI analysis and even conventional cost effectiveness analysis methods, because they fail to define the full value of health equity and social determinants of health efforts. You can see some of the critiques here, like ROI often lacks an equity analysis. We've seen this longstanding as a limitation. ROI analyses may not reflect the full value and impact of the kinds of investments in community health, health equity, including even healthcare equity efforts within the walls of hospitals and clinics. And lastly, for cost effectiveness analysis, which are essentially CEA, which is a method that's often used by policymakers, by large health plans and institutions. This method is a common economic kind of approach to be able to compare the costs and outcomes of different healthcare interventions. The problem is that integrating health equity is not part of many CEA methods at this point. And so we need to figure out ways to move beyond just looking at the efficiency of the cost effectiveness of a particular intervention compared to another, but think about how to analyze a program's benefits across different population groups. So there's limitations in the current model. So we go to the next slide. What we've been doing at Health Begins and in partnership with Dr. Harris and others across vanguards across the country is showing that there's ways that we can create better models, right, to do financial modeling for health equity work. If you advance the slide, there's ways to capture not just financial value, but also economic value, meaning how do we assign monetary value to the indirect benefits that accrue from investing in community health and health equity efforts. If you go to the next slide, if you advance one more, yep, perfect. Social value is another example. How do we capture the benefits and assign monetary value to things that are the benefits that are afforded to others outside of the investing organization, outside of a hospital or a health plan or a public health department? What about the benefits to the broader community or to household members of a patient? We need to be able to capture financial, economic, and social value. So for this first concrete opportunity that I think exists in this moment as we face these headwinds, if you click one more time, is this opportunity for more communities to use a blended value method. The next slide kind of speaks a bit more about cost effectiveness analysis. As I mentioned, traditional analyses lack health equity considerations. This is what's called a value puzzle that some leading health economists have been describing recently as last year, describing some of the components that go into traditional cost effectiveness analysis on the left, like clinical efficacy, economic value. And what health economists are starting to now speak about more and more loudly is that we need to figure out ways methodologically to incorporate health equity into cost effectiveness analysis. And so the opportunity here, if you click one more time, is about coming together to develop consensus. How can health economists, as well as health plans, health systems, and community organizations and public health departments come together to develop standards, consensus around those standards for the best approaches for incorporating health equity? Go to the next slide. While we think about these opportunities, on the financial modeling side, there's also funding for community work. So few communities, while there's a lot of multi-sector collaboratives across the country, whether they're called accountable communities for health, community care hubs, regional hubs, or if they go by different names, these multi-sector collaboratives are robust and have proven to really drive outcomes in a lot of communities across the U.S. But many of these communities still lack the collaborative funding, the actual pool of money to be able to support their incredible efforts. So the work is happening without a collaborative work is happening without collaborative funding to support it. And so the concrete opportunity here, if you click one more time, is to think about how in this moment, especially in times of scarcity and austerity and the kind of threats that we're seeing to the integrity of institutions, the financial risks that many institutions are facing on the ground, is this not a time to think more about how to collaborate in not just the work we do, but the way we fund and pool our resources, especially to align investments from banks and CDFIs, from hospitals, especially nonprofit hospitals, from health plans that have community reinvestment requirements. How do we now come together and create even more collaborative funds that communities can use to support the important efforts to improve social determinants? Last but not least, if you go to the next slide, there's another collaborative opportunity here, which is thinking about financial backbones. Many communities that do impressive collaborative work to improve the social and structural drivers still lack the strength of a financial backbone to support the flow of capital and to get that capital out to where it needs to go. The success of these initiatives often hinges on having these strong intermediaries. In Stanford Social Innovation Review just this year, there was a really great article talking about the importance of and describing the characteristics of so-called financial backbones that can strategically orchestrate sources of capital in pursuit of collective impact. We need more thinking and more work on this work. So, like one more time, a concrete opportunity here is for every community, for policymakers, for funders, both philanthropies as well as hospitals and health plans and public health departments, how can we come together to double the number and double the strength of financial backbones in communities across the US? Now more than ever, this is an opportunity for us to think about how to collaborate. So the next slide, I think is the last slide I'll share. These are concrete opportunities. And as we get into the conversation now with, as I turn it back to Glasha, one of the things that we recognize in Health Begins, and I think is recognized by everybody on the call, is that these systemic challenges are rooted in deeper trends. If you click once, these deeper trends include trends we're seeing in healthcare over the past 50 years, which is financialization of care, the privatization and consolidation of corporate power, the upward redistribution of wealth, the erosion of institutions, and even political and civil rights and economic rights of individuals. These are deeper trends. And those trends are influenced, if you click one more time, by deeper structures that we know are really offering, in some cases, some benefits, but often are coming with a lot of challenges, especially when we think about the market fundamentalism, under-resourced public goods, the under-resourcing, the cycle of kind of starving public investments, and then also inegalitarian kind of policies that continue to kind of advance the economy and advance the country at the expense of more and more people who are left behind. And then lastly, those structures are influenced, if you click one more time, by mental models that just reinforce and propagate these structures. If we're going to be able to advance in these headwinds in this moment, I think it's important to zoom out and to understand, as always, as upstreamists, that what are the upstream drivers of these systemic challenges for financing and equity in this moment? And how do we recognize that as we tackle these specific challenges, whether it's financial modeling, collaborative funds, that we also come together in a common ethos, a common commitment to a transformed political economy of health that can truly address the underlying structures that continue to kind of put us in harm's way. With that, that's my level setting. Glash, I'll turn it back to you.
Thanks so much, Rishi, both for grounding us in the reality of the headwinds that we're experiencing and offering some strategies that can help us move this work forward. And now I'd love to bring in Christina and Karen to help us further contextualize where we are now and the options in front of us. So Christina and Karen, drawing on your experience at the policy and program levels, what are one or two key lessons from the past decade that we should revisit now as we think about financing and investments for health equity and the social drivers of health? And Christina, can you kick us off?
Sure. Thanks for having me. And thanks, Rishi, for that fantastic opening. I think I'm speaking as the leader of a health equity mission and drive across a health system. If I reflect on the last decade, there has been a lot of regulatory changes that have really influenced hospitals, elevated health equity as a mission. And I think it's always kind of been there from a hospital standpoint. But finally, we got to the point of having some real concrete rules, regulations, policies that allowed hospitals to, or required that hospitals really start to get in and do this work. And that has been very influential, I would say, in thinking about where hospital systems see themselves now and how we view our responsibility. But if we think about the full totality of this time, we also can see how changing of regulations and peeling back of requirements can really risk that going away if it is not really baked in at the time. And so for me, as I reflect on the last 10 years, it has been very critical, this idea of like really embedding equity in to all of the places where hospitals are known to play. So quality, patient safety, these are things that we've been doing for decades. It's not a question. There's no ROI requirements there. And it's like equity is intricately involved in that. And so I think the hospitals and clinic systems that use the regulations and CMS and Joint Commission and started to embed it intricately are the ones that are probably being able to continue it as we're seeing some of these changes roll back. And so I think this idea of integrating equity, and it's just not something we do, it's how we do it. It has to be system work. If not, it's just too easy to pluck off and not see the gains. And then I guess the other thing from thinking about 10 years, I think about COVID, and it's been so clear. And as Rishi was doing the slides, it's just a fantastic reminder of how truly connected we are to each other from a public health standpoint, hospital, CBO. COVID, really showed that. When public health started to maybe lose public trust or not get, as a hospital, we saw the implications of that. So, I think it's sometimes hospitals think like, oh, we can't be everything to everyone. We're trying to do the best we can, but we are so connected. We are not on this hill. And that, I think, was a fantastic reminder that we have to come together. We have to be connected with each other. And I think that has some serious implications to think about how we finance this work going forward, as Rishi was mentioning. So we'll talk about some of that more later. Thanks, Kasia.
Thanks so much, Christina. Karen would love to hear your lessons from the last decade when it comes to this work.
Sure, and thanks, Christina. I think that was very helpful. I'm sort of coming to this today more from the public health perspective, in particular governmental public health. And so I guess one of the lessons learned is we've been dealing with this stuff for a long time. This is not new. And I think that what happened in the last half decade, perhaps, is that it was being named in a way that it had not been named before. We were talking about health disparities before. The terminology, social terms of health, didn't really become a governmental term until actually the first Trump administration,
No.
which which I think brought in perhaps a larger constituency. But then in the last 4 or 5 years, that ability to name things, to actually be able to, I would say, perhaps be more strategic. And I do think for public health, this is what we do, right? I mean, we have in public health really focused our attention for a very long time on those populations that are bearing an undue burden of challenges. And as in public health, as you begin to address particular issues, what you'll often see is that there are certain interventions that will gain some traction with perhaps even a large portion of a population, but then you are still dealing with populations where the messages are not getting through, where you aren't necessarily working with the community members that you need to be working with, and those then require a different vision, a different way of thinking about those strategies and engaging community partners who are going to help. And I think we did see a lot of this during COVID. I think that's when it got amplified. But again, I would say for anyone listening from the public health perspective, this is things we have been working on for a very long time. I would say that what is very unique and new now is that there seems to be dollars from healthcare that are going to get spent. I hope that we continue this because the physician fee schedules are shifting a little bit. But for the first time, the health system is thinking about actually contributing financial resources to these social determinants. Now, that in and of itself raises questions, because I think a lesson learned is often that as you begin to see the healthcare system enter into what has historically been a more public health or even a public responsibility, then all eyes turn to the healthcare system for financial support. And I will say, and I don't know if Christine will support me in this, but I don't think the healthcare system is going to
I
be able to
support you, Karen.
okay, all of this stuff. And so I think that this is a new area. It is definitely causing a lot of shifts and challenges across the field as organizations, Rishi mentioned a couple of them, community care hubs, things like that, anchor organizations are trying to figure out, can we make a go out of this in a sustainable way from dollars coming out of the healthcare system? And I've always been one to say the likely answer is going to be no, because we've seen this happen historically. For example, I worked in school-based healthcare for a long time. We never were able to actually get to a sustainable outcome strictly with healthcare dollars. Obviously, everyone's worried right now about healthcare dollars increasing. And so, we all really should be in this to sort of figure out how we're reducing healthcare costs. So I think those are some of the tangible things that we need to be thinking about, because we do have this habit in this country of sort of repeating our, the same thing sort of over and over again. And so I feel like the lessons learned come from perhaps, for example, I think HIV saw a lot of this kind of activity, lots of community activities, then looking to the healthcare system to support those efforts. And I think it's well worth our while thinking about how those efforts evolved and what was successful about them, but also what should the public sector continue to support.
Thank you so much, Karen. It's really helpful to hear about what has changed in the last decade. But as we all know, and as you mentioned, there are things that just have remained the same. This is a lot of what we're doing now isn't new. And so I would love for you each to speak about, again, when it comes to financing health equity, what really hasn't changed in the current environment? What is still the case that is either supporting health equity investments or jeopardizing them?
Karen, do you want to start and I'll go after?
Oh, sure. I was going to say she's going to call on us, so she just jump in.
Like,
Well, I would say, first of all, realistically, these kinds of efforts, these health equity, these social determinants efforts, generally were not getting federal dollars in the past. So all of these multi-sector partnerships were often supported by some combination of foundation dollars or philanthropy dollars, maybe some public dollars from counties or local jurisdictions, maybe some community benefit dollars, which I'm sure Christina may talk a little bit about. But bottom line is they were kind of put together with little bits of glue here and there. And it wasn't until fairly recently that we began to see some dollars flowing. I can say within the CDC, we actually, for the first time several years ago, got a line item specifically focused on social determinants of health. But it was a line item that was initially targeted to grow substantially and then did not, and remained for federal government at a really pretty small level, mostly being used for planning purposes and very little for interventions. So while there was this opening that was going on about funding, I would not argue that that's really where the sources for this kind of activities were going on. And I do think that, so to some extent, again, what changes, what remains the same. I still think we are, as Rishi mentioned earlier, I'm an incredible fan of multi-sector partnerships. I've done a lot of work in this area. We've published a lot on it. We've demonstrated through a variety of modeling exercises that it pays. But the reality is we do not invest heavily in maintaining these multi-sector partnerships. And so even those that are really successful, that have been around for more than 10 years, are still fighting the sustainability.
Thanks, Karen. Christina, would love to hear your thoughts too.
I mean, I guess what hasn't changed, there's a lot been changing in the environment, but what hasn't changed clearly is the need. And in fact, I think the need is increasing to do this work correctly and together. And it is going to be even more challenged with the headwinds that are coming, 100%. I think, Karen, you mentioned like community benefit dollars. As a nonprofit institution, we've always done our part from a community benefit standpoint. And I think we have at least doubled down in our supporting in the social care space, not only from within our walls of our institution and how we think about health-related social needs, but really partnering with our community, our CBOs, to support social needs, support them from a capacity making, a capacity building standpoint as well. Understanding that our CBOs are really doing the good work and are and continuing to do this work is going to get harder. So I think that for us at least, that giving profile has been deepened. And I think, also what kind of continues is, and I think we'll get into this, like this idea of value and thinking about what value is and kind of expanding that definition. I think this idea of a value proposition has always been around and continues in this current environment. And as hospitals and clinic systems that think about value in dollars and ROIs often, I think we are having to, we're in this game and we want to expand the definition of what value looks like in order to really propagate this work going forward. So.
Thanks, Christina. So we've talked a little bit about, what's changed in the past decade, what has stayed the same, and Rishi highlighted a few promising pathways like financial modeling, financial backbones, and collaborative funds. And so I'm curious to hear from you two, what are additional ideas for community, institutional, and state policies that, could help move the concrete opportunities forward? So Christina, to start, could you speak a little bit to institutional policies, maybe specifically for financial modeling?
Sure. So if I'm thinking like institutional modeling from within our own walls, before we think about partnering across different sectors, I have to think about how we're aligning within our own hospital. I think one thing that we have realized is that this work and investment, especially at big institutions, can get done, some in the research realm, in the financial realm, in the community benefit, in the social care, health-related social need piece of it all. And, if we're not paying attention, and sometimes we're so busy in our own little silos, we have the potential of not even aligning internally. And I think so before we can align externally, we have to make sure that we are coordinated in how we want to have our own impact. And so I also think there's, of course, large opportunities to partner with, state and county, and I have a lot of health equity colleagues across the country, and it can be hard coming from, we're in Los Angeles, and Los Angeles County is big, and there's lots of different communities, and so working at the county level has been very important. Thinking about how we partner with our payers, I have been very pleasantly not surprised, but I've loved learning about how our providers and our Medicaid big players in Los Angeles are really also investing. And it's so easy to just do it in silos because it's hard to come together because who's the convener of that coming together? It can be quite challenging, especially in a large city, county with large populations. And so I think that maybe I'm just naming all of the problems and all of the barriers to overcome. But this is the work that is to be done. Thinking about fighting the fragmentation that can definitely exist.
Thanks, Christina. And Karen, would love to hear about what states or local communities can do to enable things like collaborative funds or other multi-sector collaboratives.
Well, first of all, I agree with Christina. I think you often need, to some extent, a neutral convene. So as a prior health department director at the county level, I thought that we could play that role because we didn't have kind of the vested interest that so many of our healthcare providers had, and kind of overcoming some of the competition between them. You did need a neutral party. I don't think it has to be a health department. There are certainly other organizations that can play that role, but You know, if anyone knows about Public Health 3.0, that is sort of one of the modern expectations of a local health department. However, with that said, what often happens is that you can get the people together, you can get people even thinking creatively about their priorities, and yet getting them to part with their cash is pretty difficult. And the reason I say that is because sometimes you'll get them to invest in an in-kind manner, right? They'll give you a part of a person, they'll let you use their space, they might even provide food or something like that for your meetings. But in terms of actually sustaining a coordinator or something like that, you find yourself looking to your local funders, for example, to provide that, or trying to incorporate it into your county budget. So those strategies have generally worked, but they were never easy. And I think we are entering a time now where decisions about priorities are going to get made. I saw someone in the chat's already talking about Medicaid. And one of the things that I'm hearing now is that as states really look at their budgets, they're going to have to make some hard decisions. So I used to be in Allegheny County. That's where I was a health department director, which is in Pennsylvania. And I was talking to one of my colleagues there who is a funder, and we had a very rich philanthropic community. And the individual was telling me that without a budget at the state level, there was incredible fear that many of the community organizations would not have enough resources to meet their payroll. So decisions are less likely to be as innovative, perhaps, as they might be in another time, and much more about filling holes and deciding which of the holes are going to get filled. Now, sometimes I will argue that when you have stress or crisis, it brings people together and it helps to drive towards some consensus in terms of where you want to share your resources. Communities are amazing when they collaborate together to get jobs done. And they are able to do so. They really, truly are. I've seen unbelievably remarkable change in communities, almost all focused on some level of social determinants of health and equity. But people have got to get to the place where they see this to some extent as an emergent crisis and where they're willing to say, yes, we've got to sit at this table and we've got to put all of our components on the table so that we can get the success that we want.
Karen, don't you feel like we're at that point? I feel like we are so close to that. If we're not at that point now, I'd hate to see what the situation has to be to get us to that point.
Oh, I think we're there, but I think what we haven't seen yet, Christina, is how states are going to be readjusting to understand if that's going to end up strictly as healthcare, for example, or if there's also going to, I know people are struggling with the housing issues and how, when you have less, how you decide. I always say that access kind of actually trumps a lot of prevention, right? And there is some concern that as access diminishes, then the forces will be focusing there and not necessarily on these social determinants.
Absolutely. Really appreciate you both sharing these insights, and I'm seeing lots of great conversation in the chat. We're going to bring in some questions from the audience in a moment. Before we transition over to Q&A, would love to hear from you if you can leave folks on this call with one strategy to protect and sustain equity work over the next 12 months. What would it be? Karen, love to hear from you first.
Boy, over the next couple of months, I think it's partly what Christina was talking about. I think as communities begin to understand the impact of the changes that are happening at the federal level and begin, which I think they're already starting to plan for, and begin to turn their attention to those most critical issues for their communities. I happen to be also a believer that everything's local, that each community is sort of different, and engaging the people within the community to help decide where are we putting our efforts. Whether that's going to be about making sure people have their food security covered, whether that's really about making sure that their housing issues are dealt with, whether that's really about affordability of healthcare, which I'm very concerned about, and that sort of bleeds into the access issues. But I do think that this is where I would say you've got to get your governmental people in there, you've got to get your community leaders in there, bring in your philanthropy and your businesses, because ultimately businesses want their employees to be healthy, right? And they're willing to invest as a community partner, I think, in a lot of ways. I will say that, we'll see communities, I think, doing all kinds of different things. I mean, we may see changes in real estate taxes, for example, to support some things that are no longer supported now. Rishi, I don't think you mentioned that, but real estate taxes are sort of the way most local communities get their funding for human services, for example. So I think that there are going to be wrinkles that we have not necessarily anticipated. And I would also suggest that my hope is that the philanthropy community can come together in a more organized fashion to help support what those priorities might be for a local community.
Thanks, Karen. How about you, Christina?
So thinking locally, if I'm, thinking about the next few months, I think that, it is easy to do the right thing in this equity space when, there are not huge financial pressures. And I think we can universally say the money's about to get funny for everybody. CBOs, hospitals, like changes, like winter is coming. And I think for us, that means that we have doubled down on trying to really paint the picture of the health equity work that we have invested in and the broad, big picture value that it is bringing. So the value that it is generating and the value protections as well. And that is the work that we needed to do because the CFOs across the country are figuring out what has to stay and what doesn't have to. And we kind of mentioned this idea of, healthcare costs rising. Like, we know the answer to this. Like, if we continue to ignore the health equity pieces, the costs are going to go up. How do I show that? And so that's, this is not a commercial, but I will give a plug to Health Begins and their value model that they are proposing, because I think we have been way too narrow in healthcare. And if we know that all of these pieces, you don't have to be a primary care doctor to know, or public health professional to know that the social pieces, communities, like, it makes a difference. And we will not survive as healthcare institutions if we are not paying attention to that, period, full stop. But it is really hard to show that value. And that is why we need institutions to be helping on that front, because we're all trying to make that case. And we know that it is not just a dollar thing, right? So just thinking about the broadening of it. So yes, of course it is dollars, but we're also wanting to prevent, lawsuits and risk and falling out of compliance and all of the things as well. And that equates to dollars down the line. So, but when people get myopic because the money gets funny, they forget that. And so that's why we're spending the time to prove that.
Thanks so much, Christina and Karen, for answering my questions. Now I want to bring in some audience questions. So the first one I'm going to read here. My impression is that hopeful visions of scale and impact that's been driving this field was pretty contingent on Medicaid funding. Is it feasible to expect philanthropy and local government budgets to meaningfully address social needs at significant scale in ways that actually integrate our existing healthcare system? I know that's a big one. Either of you want to start?
So I guess I would say that I gotta, again, coming more from the community perspective, from the public health perspective, we never were relying on healthcare to do this work. It was always really something that we were looking to community partners to kind of build and drive, and philanthropy would get behind that generally. Philanthropy, at least in the jurisdictions I was in, was not particularly interested in necessarily funding the healthcare system, because the healthcare system, and no offense, Christina, was sort of always seen as the deep pockets, right? And so the dollars from philanthropy were often going to public health, human services, and things like that to drive these changes in the external to healthcare environment as well. I do think, and I mentioned this earlier, that with this move towards the health-related social needs, you now have healthcare, I think, expanding their purview in a way, which, we can have a discussion about if that's a good or bad thing, but recognizing that they've got to play a role in understanding those needs of their own patient population if they expect to see any kind of return on investment, honestly, right? So But I would also say that healthcare, and Christina's already talked about this, works on a very, very sort of different set of rules than community organizations or government. And when we bring them together, that so for me, and I'm a physician, I'm a primary care doc too, the incremental nature of healthcare at this point in time, even with value-based and all that other stuff, it's still pretty incremental. If now the public health system, the community services system wants to get resources out of the healthcare system, they got to play the game. They got to be involved in incrementally billing for these services and building an enormously new infrastructure to actually play in that field. And I think that's something that is getting talked about, but I don't know that organizations really understand the dimensions of that. I was at one meeting where the homeless folks were saying it takes minimally a year and a half to set up the infrastructure to be able to actually bill for those services. So I think these are the things that we're going to have to really grapple with as we pull in healthcare in a different way, not just individual by individual, but really at a community population-based manner as a partner in these social determinants of health equity.
Thanks so much, Karen. Christina, anything you would want to add to that?
I mean, I agree, and boy, I wish I had a crystal ball on this one. But I just, Glasha, when you read the question, it just made me think like, healthcare. We are in this game now, right? Some of us have been in it for a while, but universally people are in it, and we have seen the huge benefits that, let's say in California, CalAIM has been. It's been great. We've been able to show up for patients and use our payers in different ways that like the benefit is so obvious, not only in the outcomes, but in all of the incredible stories of because it takes a lot to navigate people and to connect them to care. And we have seen that work. And I think there is a fear that what happens when that goes away, like does it all just disappear and we go back to the just straight up biomedical model? But I think that we've seen the proof such that I don't think that we are going to be able to go back, because I think as healthcare systems, we understand that we need that biopsychosocial model. I think many of us knew it beforehand. The social workers are like, hello, we've been talking about this forever. And, healthcare is like, oh yeah, what are these social issues? But it's been so clear that I think that if, CalAIM and what have you kind of, or different payer models dry up, like we have to find a better way. Because if not, like we're not doing our mission, which is maintaining health. So, and even if it goes away, I'm happy to have had this exposure for even the short little window that we have had, because I think, as Karen said, never, it is that time of duress when people come to have more creative. And so I think that we don't know what the right answer is, but we're going to get there, because we're being pressure tested right now.
Thanks, Christina. I think it speaks to the role that, policy and government can play in kind of seeding, innovation and pilots and minimum viable products as a way to prove, that something works, and then, have these institutions kind of adopt them on a longer term basis. Thanks for sharing that. Another question here, how have you been successful in bringing businesses or employers into this work, specifically having them help pay for the health and community in which they exist, serve, and employ? Christina, would love to hear from you.
Bringing businesses and employers along. I think I'm not sure how to answer that one. I guess from a business's standpoint, I mean, clearly we partner with local chambers of commerce and that sort of piece, thinking about the economic engine that is so important in driving all of these social care factors. So I think our involvement through local chambers of commerce is very important, because they have a very important voice in this as the employers of the community. Again, I think, convenings, the conveners, coming back to like, what is the best neutral convener for these collaborations, is can be a challenge, and being able to ensure that everybody's getting their competing demands met. I probably am not able to go so deep into it. It's just not the space that I've been as closely, working on. Karen, I don't know if you have more experience
Oh,
on that piece.
no, I was going to say, I think that first of all, remember healthcare is a business too. So when we start talking about businesses, there's a lot of different kind of businesses. There are
Or a big
nonprofit
old
businesses,
business.
there are for-profit businesses. In the for-profit space, please remember that these organizations are paying taxes. And how those taxes get utilized is often a decision of government. And I think that's something to also bear in mind, because certainly when I spent a lot of time in Cambridge, Massachusetts, those taxes were what helped to change public ways, for example, build a bike path, perhaps even consider a bridge across a crowded intersection, things like that that we don't always think about. But definitely that built environment is part of social determinants and health equity for sure, particularly when you think about how communities have been divided, whether it's like building a supermarket in an area where there hasn't been a supermarket, things like that, where business is actually incredibly critical to bringing those things together. So when I think about the role of business, I think of it as obviously their employees. What are the services that they're offering their employees? Do they have an employee wellness program? Are they thinking about policies within their organization? Do they have a variety of opportunities for their own employees? But then I think about policy, systems, and environment. And I do think that businesses can be very supportive and helpful of regulatory policies, particularly things like I said, the built environment, strategies, the no smoking strategies, all those kinds of things where you really need business on board. I remember all the trans fat work that got done, which may not strike people as a social determinant of health, but if you think about how businesses really need to be in the mix to get those policies passed, even though the policy has to be passed basically by government. So when we think about it, again, we tend to get into this rut where we say, the only good dollars are dollars that are given to you as a contribution or as a grant. But please remember that grants are generally, even if you can get them, they're short term. They don't go on forever. And if you can actually shift policy and shift environment and shift these systems, I think you've got a much better chance for sustainability. And that's where I really think that business can play an important role.
Yeah, I completely agree. Yeah, these grants go away,
Yeah. I would love to have one more question from the audience, and just a note to the audience. I see that you all are sharing a lot of what you've seen working in your community, whether it's specific financing models, multi-sector collaboratives, et cetera. So please keep sharing. We'll kind of compile a list and share out with you all so you can benefit from that as well. So the last one, what are some of your ongoing efforts or interventions at your institutions or with your partners that have demonstrated a positive ROI or blended value? And how have you been able to scale your story during these uncertain times? Christina, go first.
I think we have a fairly big grant making portfolio at Cedars-Sinai, kind of probably around 25 million a year. And we just did a 10-year, well, maybe it wasn't 10 year, I think it was a multiple year look back to understand how not only like the number of lives that have been touched and the number of programs, but also like what has come of these programs, 5 years out. And I think about our investing specifically in the Black birth equity space and really supporting local organizations who are closer to the communities, trusted relationships, in continuing to be able to do the work that they've done and improving outcomes from that they're tracking locally. We, of course, as a hospital system, look at our outcomes and track improvements, but our data is our data and their data is their data. And so I think our I think it's like $4 or $5 million that we've invested, just local Los Angeles Black Birth Equity it's made a difference. It's made a difference in who's getting access to care, who's following up care, postpartum visits and such. And that feels good. I think it's a very important population and to think about, across the country. And that work continues to be done. And so I'm proud of some of that work. So that's what comes to mind.
Thanks, Christina. How about you, Karen?
Well, I'm not running programs anymore because I'm no longer at CDC, so I don't have that kind of portfolio. Some of the things that we did at CDC that I think were in this space was we did identify a group of over 42 partnerships that were doing successful social determinants of health work. And then we promptly did a rapid review working with partners and essentially were able to demonstrate a return on investment of those multi-sector partnerships. And there's I'm happy to provide a couple of papers that were written on that subject. But, as I hearken back to, again, my work at the local level, which was the vast majority of my career, I want to do a shout out. I don't know if there's anybody from Pittsburgh on the line, but for example, my colleagues in human services there have, along with their county executive, were able to launch an initiative around homelessness. And successfully, I want to say it was maybe, I'm getting this wrong, I think it was 500 days or something like that. The bottom line is, this was an initiative that was brought to fruition by a collaboration that included the businesses in the downtown area that really felt like the homelessness was causing a problem for them as well, and the social services group. And they were able to identify in that period of time places for all of those individuals. And again, I may be over amplifying it, but I try to follow them regularly to see their success. And I think it's those kinds of things where you see the community coming together. Perhaps maybe they had different agendas, but they were able to coalesce and do the work that needed to be done and see unbelievable success.
Thank you both. And really thank you, Rishi, for setting the stage, and Christina and Karen for coming together, sharing some of your insights and wisdom. Really just want to say this is kind of the beginning of this conversation. Obviously, we can't talk about all the strategies in 1 hour, but I want to turn it over to Rishi just to share a couple ways to stay involved in the conversation before we wrap up.
Thanks, Glasha. If we can share a screen really quickly, I also just to commend the incredibly rich conversation. So there's next steps. Complete the follow-up survey, which will appear in your browser as soon as the webinar ends. Please stick around for a minute just to complete that. It really helps us understand what you enjoyed and what we can improve upon. Share your comments in social media, tagging Health Begins and our colleagues as well. Take action, and I'll give you an example if you go to the next slide about ways to take action, including just following our work at Health Begins and sharing your work so we can amplify it. Whether it's around financial modeling, which is like using better tools to capture value of the work that we're doing, financial, economic, and social, or whether it's setting standards for how to create collaborative funds, or even how to strengthen financial backbones, or even kind of go further upstream to talk about tax policy and other macroeconomic kind of changes like was mentioned in the dialogue. What we clearly lack in this space is a convener to help bring together, not just at a community level, but to bring all of us in public health and healthcare and the social sector and in pro-democracy kind of efforts to come together to think about the standards that we need to be able to push for, the policy reforms we need to unlock in order to make sure that capital is going to work to the communities that need them and to invest in the programs that we need to see. So a coalition for health equity and financing is being planned right now. There's a convening in Berkeley in February. If you're interested in learning more about this, this coalition that we're helping to plan with others, especially the meeting in Berkeley in February, please sign up using the form that I believe is in the chat as well. So let us know if you're interested in learning more about this and staying in touch. Thanks.
Thanks, everyone. Grace, can you close us out, please?
Sure thing. I think Richie hit a couple of the key points, but all you need to know is you will see that survey pop up on your screen. Your input really does shape the plans that we make for future webinars, and we would appreciate you chiming in. You will be receiving a recording of the webinar and the slides by email. Keep an eye on your inboxes for that. And lastly, this is clearly an ongoing conversation. It could have gone on even longer this morning. So let's continue it. In the meantime, on Blue Sky and LinkedIn, you can see our handles there in the chat. And We look forward to continuing this with you on our next webinar. Thanks so much.